show my experience with Aflibercept, nothing more, no literature, except 1 or 2 slides maybe. So my experience with Aflibercept in DME, and though it is a supported talk, it is totally based on patient benefit. So we know Aflibercept has a high affinity binding to VEGF as well as PGF. And this dual action gives it very high efficacy, as well as there is a long duration of action in the vitreous. So initially we used to use Aflibercept only for cases that were not responding to other drugs, including steroids. But then when we started using for these resistant cases, we realized a host of benefits. We saw the efficacy, the speed of response, and the longevity of response, which led to reduced treatment burden. And in addition, this all came with zero adverse events of other agents. Raised IOP, cataract, inflammation, contamination, none of these are there. And then the anti-VEGFs also have the advantage over steroid of reducing the diabetic retinopathy severity score, the proliferative component. And so these are the first line of agents for DME management as per all international guidelines, anti-VEGF drugs over steroids. So these are my initial cases in 2017-18, where we used to come to Aflibercept as a last resort. Now this is a patient in 2017, already tried ranibizumab elsewhere, so not working. We tried intravitreal triamcinolone because patient couldn't afford dexamethasone. And initially he responded to every 3-month IVTA, and then we required to give him every month because there was no response. But he stopped responding even to monthly. We wasted 1.5 years with monthly IVTA. Then he agreed to shift to dex implant, no response. In 2 weeks there was a recurrence. Again we wasted 6 months with 2 implants, and finally he agreed at the end of 3 or 4 years, he agreed to Aflibercept, at which time there was an immediate flattening of the macula with improvement in vision to 6/18, which was a remarkable vision for him. And now we called him every month expecting to inject every month, but he required an injection only after 5 months. And subsequently, in the last 2 years, we have injected him only every 4 to 5 months. And from December 22, he did not require any injection till I just came in October. So 10 months interval. So the response was superior to dex implant. It was lasting for 4 to 10 months. Earlier switch may have preserved better vision because we damaged his macula. And so it has now become the drug of first choice for me in every case, whether it's a pseudophakic also. So this is another patient to illustrate a similar thing. Ranibizumab was given, vision was good, shifted to steroid, but the vision deteriorated. So gave an Eylea, vision improved to 6/12 and 12. We thought we can maintain with the steroid. So for almost 2 years, we maintained on steroid, but the vision became extremely poor. So again added Aflibercept. Now you see the Aflibercept is not improving the anatomy much, but within 2 injections, vision has come to 6, 9, and 6. So now he was willing to take it every 2 months, and we have been able to keep him at 2 to 3, 4 months with good vision, reasonably good vision. Decided to add a dex implant for additional effect. That did not improve the vision, though the anatomy improved slightly. So here again we had tried steroid including dex implant, and the visual result, though the anatomy was not much better with Aflibercept over the dex implant, but the vision was much superior, irrespective of the anatomy. So most of my patients subsequently had to shift from dex to anti-VEGF. So now I go directly to Aflibercept rather than going via the steroid route. This is a patient already tried ranibizumab. We gave Aflibercept, immediate improvement in vision. He was very happy. And then we are injecting him only at 9 months with excellent vision. And then at 12 months only. And vision is N6. He's a clerk, bilateral injections. So long treatment intervals with visual results superior to anatomic results, and near vision improving more than distance vision, which is what most of the patients need. Now to touch on the hard exudates, as the previous speaker, Dr. Chandramohan mentioned, systemic control is extremely important, lipids control especially, but ultimately you do also have to treat them with injections. They are more dangerous, so prevention is better than cure for these. This is a lady who came with, she had received Ozurdex already outside. When she came to me, within 1 injection of Aflibercept, there was significant improvement, anatomy and vision, but then she was lost to follow-up for 8 months, so she again increased exudates. Again, we treated her every 2 months with marked improvement. By June of this year, there was almost no exudate, but started increasing again because she had very high triglycerides again. So that is also very important. Just injections are not enough. You have to control the lipids and sugar as well as blood pressure. But you see then, subsequently with control, everything is gone, the fluid as well as the exudates. So in 2 years, this lady, we could bring her away from the, sorry?
No, slides are not coming here. It's okay.
Okay, this is another patient, bilateral, with 2 injections of Aflibercept, we could remove the exudates completely.
Like this, if something is happening here.
The screen is not working.
भाई ऑडियो विजुअल ये इस हॉल में होता है, इस हॉल में पहले भी था, बार-बार वो आके प्रेस करते हैं.
Okay, so this is what the. So this is another patient with bilaterally 2 injections of Aflibercept with complete resolution of exudates, and then we follow it up with laser for long-term effect. Another patient, bilateral, also has PDR with hemorrhage, and you see with 1 injection of Aflibercept, exudates have gone as well. So Aflibercept is effective in the treatment of hard exudates. Steroid is not a default therapy for hard exudates because it has complications and adverse effects. Significant resolution can happen, but it requires more intensive and longer term treatment. If you give longer intervals of treatment, there is progression of hard exudates. Now sometimes the anatomy doesn't improve, but the vision improves so much that patients insist on taking these injections. This is a patient who comes, and then finally even the anatomy improved. But the vision improves more than that. This fellow eye of the same patient underwent phaco-vitrectomy, developed edema. We gave in steroid, pressure went up, so we gave Aflibercept. Again, we get a good response in a vitrectomized eye. And this effect lasts for 3 to 4 months, so which is the same as a steroid. Again, a vitrectomized eye, the effect lasts for about 3 months with a Aflibercept. Most of the time when we try to give steroid in these patients, at least 30 to 40% patients, there's a pressure goes high. So now we use it as a first-line therapy, as I said. We don't really spend time with other agents. And you can see with 1 injection, the vision is going on improving, and even at 5 months, the vision has improved to N8. And the recurrence has happened only at 14 months after the last injection. And the other eye has responded like this. We gave in 1 eye, and you see the other eye with marked vision improvement. So then in all this, where to consider steroids? Only when anti-VEGFs are contraindicated, which is in pregnancy, recent cardiovascular events, severe renal dysfunction, or when there is traction with active neovascularization, because anti-VEGF can increase the traction. Avoid steroids in glaucoma, immunocompromised patients, and where the posterior capsule is absent, because it can migrate to the AC, causing an emergency situation. Thank you.
Thank you, Dr. Mallika. A very well reasoned presentation where you've stated your points very clearly.
Thanks.
I would just like to know, were there cases where the cases which did not respond to Aflibercept and they would have responded to, like the series you showed where the macular edema persisted? You said the patient's vision went on improving, but there was a lot of edema. Do you think this patient would have responded to steroid if you had tried it?
Yeah, Dr. Tinku, I have tried that route so many times since 2015-16. So many innumerable patients. We used to first give Dex, then go to Aflibercept after not getting a response. And maybe a couple of patients I would have then tried going the opposite way. But I have never had a patient who's satisfied with Dex implant, whether it's RVO or DME. They say the vision was better with the previous one, please go back to that. So I have not had the other way around, no.
So you don't mind keeping that edema for such a prolonged time?
I can't,
if you had tried
I have no choice. It's not that I mind, of course I mind, but I don't have a choice.
So ma'am,
Mallika, once you say that, a lot of your patients had the effect ranging from 4 to 10 months.
Yes.
What does it mean? What does it mean? Meaning thereby patient requires every 4 or 5 months?
Yes.
Does that mean the pharmacokinetics have changed? That, the duration of action has changed? Why is it that initially they were requiring, is it that you have to blast it initially and then maintaining?
Possibly the VEGF load was very high earlier, and then it starts getting neutralized, plus the patients may become more conscious, so they start controlling their systemic disease better maybe. And there is a flow and ebb with the chemicals in the eye.
So you no longer give Avastin, you no longer give ranibizumab, You only give Aflibercept?
So ranibizumab, occasionally when there is a very mild edema, vision is 6-9, there we can give it because we need only that much effect. But anything more than, worse than 6-12 or a severe looking cystoid macular, severe looking edema, I go to Aflibercept because longer action, less injections, and maybe no more injections many times.
Economically?
Sorry, sir?
Economically?
Economically, sir, most patients' economy is good. If the efficacy is good, that's economy enough. Rather than struggling with something which is not working well or coming repeatedly every month, then the economy is actually worse.
So I agree with you. I agree with you that today, world over, I think after that protocol T came up, and all of us have had wonderful experiences with Aflibercept, and I may not have any doubt to say that today, although protocol T says poor vision and better vision, all these things, still I think today Eylea or Aflibercept 2 milligram assumes the number one position in management of DME to begin with.
Absolutely.
Is that correct?
Absolutely. 100%.
You,
One more point. Is there any role of IVTA giving with ranibizumab together in one sitting and then fill in with ranibizumab in between for patients who can't afford? So
Siddharth, you can do any jugglery what you want, but till the time you have a lot of data collection with you to show all these things. You see, IVTA went into disrepute because if there is a high pressure response with IVTA, it's very difficult to manage. You have to do with tetemy and all. But IVTA, I'm telling you, we all started with IVTA. And all of us have wonderful slides to show the effect of IVTA also. There's no doubt in that. That a lot of people say IVTA is a poor man's Ozutrex. But IVTA does have a place in the management of...
that's what we have
Yeah,
seen.
I have a number of cases where, let me complete. Number of cases where multiple injections were taken, diabetic macular edema, taken elsewhere, with poor systemic control and no emphasis was given for control of the systems. And only by controlling the systems, the injections were totally not required for them. And they said that this is what is this miracle that has happened, that without injections I'm resolving. So in your cases, few cases I have seen SMDs are there so much that it's indicative towards the systemic derangement, which is gross derangement. Unless you emphasis on systemic control, these don't respond so well, and year after year we cannot keep doing injections alone.
Absolutely. I showed a slide where exudates came back